Yeah, I am a neurologist with a specialty in movement disorders, and I run the Jeff and Dan Ross Movement Disorder Clinic here in Toronto. We are a little bit different than other places because we really focus on education and on an interdisciplinary approach to managing symptoms of Parkinson's and really focused on living well with Parkinson's. So today we are going to talk about the medications used in Parkinson's. And this is a fairly complex subject, and knowledge about medications, effects, and side effects, and how to take them really make a big difference in how well symptoms are controlled. So let me just advance here. Let's see if I can advance it. For some reason, I can't advance it. Hold on. Is that it? Nope. Okay, we have our first technical glitch. Um, hold on one sec. I may have to. Um, hold on one sec. 1 second. We are going to just make sure that everything is working appropriately. Okay. Um, okay. Hopefully this can be advanced. We aren't able to advance it. Oh, there we go. Now we did advance it. Okay. Sorry for that. Okay. So the first question is, why take medications for Parkinson's disease? So this isn't such a straightforward question. We all would like it if we could take a pill that would take away our disease. Unfortunately, right now in Parkinson's disease, there is yet no neuroprotective agent that can reverse the disease, can prevent it from progressing, or change the status of the disease in itself. However, there are some very good medications that can control symptoms really well, and it's reasonable to have a good quality of life with Parkinson's disease if the medications are managed properly. And that really is an art to some extent. So the reason to take medication is because it can provide relief of many symptoms of Parkinson's. And if you don't take medication, you may suffer symptoms which cause discomfort, reduce mobility, and independence. So then the question is, when is the right time to start taking medications? And this isn't the same answer for every person, because everybody has different set of symptoms. Everybody has a different level of comfort with those symptoms and what their goals are, how they'd like to, what symptoms need to be addressed in order for them to continue in their normal life. Usually what we counsel people is you start taking medication when symptoms are such that they bother you and interfere in what you're doing. So it may be that you have some symptoms, maybe a slight tremor, but you can live with it. It's not bothersome to you. And there's no particularly good reason to take medication yet, because as I mentioned, the medication results in symptomatic benefit, but doesn't necessarily alter the course of the disease such that you are not hurting yourself by not taking medications up front. At the same time, you're not necessarily doing yourself a favor by not taking medication if you do have symptoms that interfere in your life. And this is part of the conversation that you have to start having with your doctor in terms of finding exactly when is the right time for you. So now we'll just kind of go through an overview of what the medications are. And as many of you probably know, levodopa is sort of the mainstay of medications, and it comes in different formulations with different names. Levodopa is the generic. It is the precursor to dopamine. And some of you know this as levodopa carbidopa, and the brand name is Sinemet. There's another formulation called Prolopa, and that's levodopa benserazide, and I'll explain what carbidopa and benserazide are in a moment. Stalevo is another formulation that is a combination of levodopa carbidopa and an additional drug called entacapone. And then there's Sinemet controlled release. The other medications that I will say are the supportive medications for levodopa, because this talk is going to be mostly focused on levodopa, as that's the main medication in Parkinson's and is the one that is the most kind of finicky and requires the most understanding in how to use. The additional medications, the dopamine agonists and MAOB inhibitors and the COMT inhibitors, These are all adjuncts to levodopa, and I usually don't add them on until somebody is on levodopa and then starts to have possible complications such as wearing off of medications. Amantadine is another drug used in Parkinson's in the olden days before levodopa existed, meaning before 1969, and shortly after as well. Amantadine was sort of the first drug that was given to patients because it has some mild benefit in terms of tremor and some symptoms of Parkinson's. But really these days we use amantadine to control dyskinesias. That's our main reason to use amantadine. And then there are advanced therapies. In some people, there comes a time when, while they still respond well to levodopa, it's for a shorter and shorter period, or there may be other complications that limit the use of oral levodopa. And then there's something called duodopa, which is an intestinal infusion, a gel of levodopa, but going directly into the intestine. So we don't have time to talk about that today, but that is one of the advanced therapies. So now, which medication is right for you is the first question. And again, the choice of medications is different for every single person, and it's based on numerous different factors, including what the symptoms are and how bothersome they are, how old you may be, what are your lifestyle, what is your lifestyle, and what are your goals. For some people, it's absolutely reasonable to say, well, my golf game has gotten worse and I'd like to improve my golf game. So that may be a different story than somebody who says, well, I can't move my leg and I need to walk. Also, we have to consider other medical conditions that make you consider what are sort of risks and benefits of each of these drugs, because all drugs have both benefits but as well side effects, and we want to make sure that we don't do anything, we don't give you a drug that could potentially cause you more problems than good. So again, this is a totally individualized process. Sometimes people come and say to me, well, my friend so-and-so or the other person in the support group is taking this pill. Do you think I should take that pill? So what I always say is that what the other person is doing has absolutely no bearing on what your needs are, because every person, as I said, has completely, should have an individualized treatment plan. So now we're going to focus on levodopa as the mainstay of medications in Parkinson's. As I said, levodopa is the most effective medication. It particularly helps to reduce muscle stiffness and tremors and slowness that you sometimes see in people with Parkinson's. And sooner or later, most people with Parkinson's use levodopa to control symptoms because it is the strongest medication to control symptoms, as well as upfront with the least amount of side effects, so the least risk. And I thought I'd give you a little bit of background on how levodopa works, because this is really important in terms of what I'm going to tell you next on how to take it. So levodopa is a precursor to dopamine. Dopamine is that neurotransmitter in the brain that gets depleted. The reason it gets depleted is because cells in the brain that make dopamine in a part of the brain called the substantia nigra degenerate. Nobody knows why they degenerate, but that is the process of Parkinson's. And those cells, they make dopamine, and dopamine is an important messenger to give messages to the rest of the body on how to move and so forth. So levodopa is a precursor to dopamine, and it is ingested in the stomach, and then it is taken up into the bloodstream by a receptor, and then it is taken again from the blood stream, takes it to the brain, and it is taken up into the brain and in the brain converted to dopamine. So along the way, it needs to be protected. It can't be metabolized from levodopa to dopamine in the bloodstream or in the stomach, and that is why we have carbidopa and benserazide, those other parts of levodopa that are attached to the formulation, and that is in order to maintain it as levodopa until it gets into the brain. So here are just pictures of what your medication might look like, the levodopa. You've got the 100/25, that's the most common type of levodopa. They're usually yellow pills, although often this is generic and it may be round or or oval, maybe yellow, maybe a different color. But for the most part, we call them the little yellow pills. And again, you can also have them in strength of 250 over 25 or 100 over 10. Prolopa is that other form of levodopa with benserazide protecting it rather than carbidopa protecting it. And we call that Prolopa. And these come as capsules. And in fact, it's not shown on the screen here, but there's also 50 milligram capsules. The levodopa can be cut in half because it's a tablet, but capsules can't be cut in half. So if your doctor prescribes you 150 milligrams of Prolopa, you would take a 100 milligram capsule and a 50 milligram capsule. As I said, the 100 refers to the amount of levodopa, and the 25 refers to the amount of carbidopa. And that's the same with Prolopa in terms of the 100 referring to the levodopa and the 25 referring to the benserazide. So as I said, in summary, levodopa, we give it in order to address symptoms such as muscle stiffness and tremors, improving speed and coordination of movement, and it's a very effective treatment for Parkinson's disease. So that being said, how should we take levodopa? Frequently, I see people in my clinic who have been started on levodopa, but the doctor never necessarily told them how to take it. They just said, well, take it 2 or 3 times a day. And so people took it upon themselves to say, well, it makes sense, I'll take it when I have breakfast. Maybe I'll take it sometime around lunchtime, and then I'll take it at bedtime. And in fact, levodopa is a very particular medication. It has a certain kind of metabolism. It only lasts in the body for a certain period of time. It interacts with protein. And so actually how and when you take it is very important as to whether or not it's going to help you. So if someone comes and says, well, I think I have Parkinson's disease, or I've been told I have Parkinson's disease and I was started on levodopa and it's not helping me, I am not convinced that levodopa is not going to help them. I am convinced that we need to make sure that they're taking it in the right way before I can say that, oh no, it's not helping. And for the most part, when we confirm that really it is a diagnosis of Parkinson's disease, and then the levodopa is taken appropriately and consistently, it always helps. So just as a general guideline, and this is true usually with all medications, we always start with a low dose, and we increase the dose very slowly over weeks. So for example, if somebody comes to me as a new diagnosis of Parkinson's disease and they're not yet treated on medication, I would say to them, we're going to start with levodopa, carbidopa. We're going to give you eventually 1 pill 3 times a day. That'll be our goal. But we're going to start very slowly, giving you half a pill once a day for a week, then half a pill twice a day for a week, then half a pill 3 times a day for a week, and slowly go up by half a pill per week over a period of 6 weeks before we even get to a starting dose. And the reason I'm so cautious is I want to make sure that people can tolerate it. As I said, it's most likely, it's usually very well tolerated, but I want to be able to catch any problems that arise early on so that we can then address those problems and troubleshoot them so that people don't get discouraged with levodopa and say, no, I don't want to take it, knowing that this is the best drug that we have. Again, the medication needs to be taken up to 4-hour intervals. Some people will say, well, I take it at 3 hours, I take it at 2 hours. Absolutely. Over time, the medication may last for shorter intervals, but in general, the medication is metabolized every 4 hours, and the intervals shouldn't be much longer than 4 hours. Sometimes people say, well, I'm having my tremors wake me up at night from sleep, or I can't fall asleep because of the tremors. I have difficulty turning over in bed at night, in which case I would add a 4th dose at bedtime. But I wouldn't start people on a bedtime dose because generally, especially early on, just a small dose during the day is enough to carry people over overnight as well. And taking a dose and then going to sleep makes no sense because you're basically wasting good medication without daytime hours where you need the mobility most. So the dose at bedtime only comes if and when there are symptoms that affect sleep. It's important to be consistent with Parkinson's medication, specifically the levodopa. Many times patients come and I again, they've seen other neurologists, they've seen other doctors, and they've been told to take levodopa, but no one tells them that they have to actually take it consistently. They can't be late. They must take it on time. It's best to really set up a system where it's the same time every day. I ask people to actually have alarms to ensure that they're not forgetting. If there is a delayed onset in terms of the medication kicking in, a little trick that we often tell patients is to crush or chew the levodopa and then take it with some kind of a carbonated beverage. That seems to activate it. That's different than Prolopa, which is a capsule. So we don't obviously ask people to open the capsule, but this is specifically if you're taking levodopa. Certainly the Cinemet CR should never be crushed, the controlled release Cinemet, because in its controlled release, there's molecules in the formulation that are specifically related to it being released in a certain time, and by crushing it, you're affecting the those particular molecules. So those medications should never be crushed. Another important thing to do is never to stop taking levodopa suddenly, saying, okay, well, let's see what happens if I don't take the drug, and then just stopping it altogether. Because in rare cases, if you are taking levodopa and your body requires it, to just stop it cold turkey can really put you into a bad state. So I think most people know that medications always need to be gradually withdrawn rather than suddenly. So I was sort of alluding earlier to the fact that levodopa is very particular in how you take it, and it relates to what you eat. And the reason that is because levodopa competes with protein for that receptor to get from the stomach and into the bloodstream, and from the bloodstream into the brain. And I often tell people that in that competition, protein always wins. So if protein and levodopa are in the stomach at the same time, protein will always get taken up preferentially in that receptor, and the levodopa will get through the system without being properly absorbed. And there are many people that notice that if they in fact take levodopa with food, it doesn't work as well for them. And it's not just any food, it's specifically protein. So some people are very, very sensitive to that. And so we counsel people to take the medication on an empty stomach, usually half an hour before or 2 hours after. So that's what this picture shows. It's kind of just a timeline. So if you take your levodopa, for example, at 7 o'clock in the morning, you want to make sure you don't eat anything until about 7:30. And then you also, so that time window is about an hour and a half if it's a 4-hour period of time that you're taking the medication. So you would take your levodopa at 7, eat breakfast at sometime between 7:30 and 9, and then not eat anything again till 11 if that's the next time you take your pills. And this picture just kind of demonstrates that. So again, the time window for when you eat depends upon what the interval is for when you're taking medication. So if you take pills every 3 hours rather than every 4 hours, your time window would only be between 7:30 to 8 to have breakfast. And it can be quite difficult to be so rigid. And I appreciate that, but it really does potentially make a difference in those people that are very sensitive to the medication. Usually early on in Parkinson's, your brain is still making enough dopamine that you really just need a slight top up, and you are not so reliant from dose to dose. So you still have enough reserve, and you aren't living from dose to dose. But as in some cases, and over a period of many years, it could be that your therapeutic window, or the amount of time that you have before you need dopamine again, gets smaller and smaller, and you become more and more reliant on the drug. And in those cases, it's important to maintain that distance between protein and levodopa. Another important point in relation to this that seems peripheral but is actually related is management of constipation. And the reason that is, so people with Parkinson's tend to have constipation as one of the non-movement symptoms. And this needs to be treated very aggressively. What I mean by that is there needs to be a bowel movement every single day. And that is because when people are constipated, there's delayed gastric emptying. The stomach doesn't empty as quickly, everything's backed up. And so even if you think that you are taking your pill at 7 and not eating till 7:30, it may be that that interval doesn't allow for the stomach to empty because you're backed up. So you still have protein in your stomach, and then you take your pill at 7:30, and then the pill doesn't work as well. So managing constipation is really, really important. And once every 3 days, once every 4 days, that's too constipated. So again, as I said, the goal is every single day. And many people have a busy life, and it's really hard to remember to take pills 3 or 4 times a day. And they may have other pills that they have to take for blood pressure, for diabetes, or any other condition. And it becomes a whole production to keep track of all the pills that you have to take. And many times people come and say, I'm taking 18 pills a day. And that really is daunting. And we want to do everything possible to make it easier and not such a barrier to getting it right. And it's one of the things I always guide people to do is to just ask the pharmacist to put all their medications in a blister pack. And we tell the pharmacist exactly what time so here you can see the blister pack here says morning, noon, and evening and bedtime. And maybe for other medications, that's just fine. But for Parkinson's medications, as I had mentioned before, the timing is really important. And so we guide the pharmacist as to what those times are as well. Now, it's great to have a blister pack, but if you can't remember to take medications, and I'm the first to admit, even if I have to take antibiotics once for a period of a week, 3 times a day, it's almost impossible for me to remember to do that. So it's not a criticism of people if they can't remember. We just need to make sure that they do, and there's all kinds of different strategies in order to do that, including smartphones that have alarms. And I know the Parkinson Society, I don't know if they still do, but in the past they used to have a combo alarm and pill box. That's in the third picture, where the alarm doesn't stop ringing until you actually open that particular compartment, which I think is pretty smart, because a lot of times people say, yeah, the alarm goes off, but then I'm busy doing something and I forget after I turn off the alarm. So that's a way not to forget. So in summary, there are many different options in medications and how you use them, and it definitely changes over time as your symptoms may change. Again, it's a whole other conversation to talk about how you modify medications over time when you may require more medication when medication wears off. And I'm happy to give another webinar at some point on more advanced management, but really that's not your job, that's your doctor's job. But what is your job is to understand how the medications work and how to report to your doctor what your symptoms are so that they can help in figuring out the next steps, meaning do you change the interval of medication, do you give a higher dose of levodopa, do you then add on other medications such as the Comtan or the Azilect in order to make the medications, the levodopa, last a little bit longer, etc. So there's a lot of different options, and it's fairly complex. The doctor just needs to understand what your symptoms are to be able to help figure out the right schedule for you. I encourage you at the end of the webinar, I'll have the website of Live Well with Parkinson's, where I was quite frustrated in seeing that my patients had so little information. They would go out on the web, and there was lots of information on the web, but it wasn't really specific to what I wanted them to know and be able to understand. So that website has a lot of content that is helpful in terms of protein levodopa interactions, in terms of side effects of medications, the concepts of wearing off, and all the things that you need to be able to understand to help your doctor help you live well with Parkinson's. So now I'm just going to focus on some myths related to levodopa, because I've been practicing as a movement disorder physician now for nearly 20 years. And repeatedly, I hear over and over and over again, sorry, what just happened? I hear over and over again people having ideas that prevent them from actually making good choices about taking medication. And it's it's out there in the internet. It's out there even from neurologists or family doctors um, about about levodopa, and I want to dispel those myths to make sure that you're making the right decision at the right time. So, as I said, many times people come to me and with misinformation, and as a result of that misinformation, they've lived with years of symptoms that they didn't necessarily need to have because they were making decisions based on things that weren't true. So here is the number one myth that I found people saying to me over and over again, and again, even doctors have these ideas. So taking levodopa early makes you resistant to it in the future. I wouldn't be surprised if many of you have heard this before. So the idea is that you shouldn't waste the levodopa now when your symptoms are relatively mild, and you should save it for later when the symptoms are severe, because it's only going to work for a period of time, and therefore you should, you can live with the tremor now, you can live with some slowing down, but later on maybe things will be worse, and you don't want to already exhaust your medication. So the truth is, in the early stages of Parkinson's, as I mentioned, your brain still is making dopamine. So those cells that degenerate in the substantia nigra, in fact, they degenerate for decades prior to anyone having any knowledge of symptoms of Parkinson's. And your brain is able to compensate up until 80% of those cells have already degenerated. And at that threshold, where there's only approximately 20% of those cells left, that's when you start to see symptoms. But there's still 20% of those cells, and you still have your own dopamine. And when you take small doses, you have sort of a boost. It's kind of like a savings account. You still have enough in your checking account, but you now have a little bit in the savings account in case you need, the checking account is depleted a little bit early. You have a little bit extra, and so you're not, as I said, reliant on dose to dose. But those symptoms still bother you. And by saying, well, I'm not going to treat them now because I'm going to save it till later, you're simply just suffering. What happens over time is that a couple of things happen. First of all, in order for levodopa to work, it still needs those brain cells because they have machinery to metabolize the levodopa into dopamine. So it requires those cells for levodopa to work. If there's ongoing degeneration, which we know there is, although it may take years and years and years, levodopa won't work if your cells aren't there. So it doesn't matter whether or not you have taken levodopa early on in the course of the disease or later. If there is no machinery to metabolize it, it's not going to help you. Additionally, as time passes, there are other neurotransmitter systems in the brain that can be affected by Parkinson's. They're not just related to dopamine. So replacing dopamine for those symptoms that aren't due to a dopamine loss is not going to help you. So hopefully I've made clear that it's really in your interest when you have symptoms that interfere in your life to take the medication to improve those symptoms, to increase your quality of life, your mobility. One of the things that I always tell people is one of the reasons it's really important to take medications is also to allow you mobility, to do exercise, because exercise, in fact, is the one thing that has been proven in research to protect the brain, and maybe the only neuroprotective strategy that we have right now. So I always say to people, you have to exercise like your life depends on it, because maybe it does. And if you are struggling and you're uncomfortable, even if you're getting by, you may not be able to exercise to the extent that you could if you were thriving. And by taking medication when your symptoms are bothering you, you're optimizing your quality of life, and you're not making things worse for later. All right, so this is just a summary. How well your symptoms are controlled by levodopa in the future is not influenced by whether you take it now, and saving levodopa for later will only result in unnecessary suffering from Parkinson's symptoms now. Now, people might say, well, I'm having problems with the levodopa. It's not really controlling my symptoms after all. As I said, there may be many different reasons why the levodopa is not working, and it's important to talk to your doctor to adjust medications. And when I say doctor, I know that movement disorder specialists are kind of centered in big cities and may not be available in the more rural areas or smaller communities, but it really would be helpful to have access at least to a consultation once or twice a year by a movement disorder physician that has that skill set to make those adjustments and fine tune. So the next myth is my body will become addicted to levodopa. So people come and say, I'm afraid to start taking levodopa because what if I can't stop? Indeed, it's not that your body becomes addicted to levodopa like it would to a narcotic medication or some kind of a sedative. Your body needs levodopa because it doesn't have the dopamine made naturally. So it's not an issue of an addiction. It's just that if you don't take medication, your symptoms will be more bothersome. And if you do take medication, you'll have better control of those symptoms. It's not an issue of dependence. You can always stop levodopa. You're capable of doing so. It's not that your body's addicted to it, but your symptoms will recur. Another myth, and one that needs to be dispelled. Sorry, guys, it seems to me sometimes the computer moves without my moving it. So the people believe, they come in and say, well, this is the magic jelly bean. I'm going to take this pill and everything will get better. And that's actually not the case. So levodopa doesn't improve everything. It improves some things. It is the most effective medication for improving many Parkinson's symptoms, but there are other symptoms, for example, non-movement related symptoms such as cognitive issues, mood issues, maybe freezing of gait. They may not fully respond to levodopa. Now, I say that there's a caveat because some of these symptoms may fluctuate, meaning that they do get better when you take levodopa, and as the levodopa wears off, maybe there is a worsened thinking or a worsened mood, or the walking becomes worse. Yes, that's and adjusting levodopa definitely helps with that. But sometimes there are symptoms that are present, such as cognitive impairment or mood symptoms, regardless of if the levodopa is working or not. And those symptoms aren't improved with levodopa and need to be addressed on their own. So a psychiatrist might help with regards to mood symptoms. A cognitive behavioral neurologist may be able to help with some thinking issues, but levodopa does not cure everything. And also, it may be that initially levodopa does control all the symptoms, but as time passes, if there are additional problems that accumulate, levodopa will not be able to cure those specific problems or improve those symptoms. There are other strategies that we look at when people appear to be resistant to the effects of levodopa. And again, I use that's kind of a broad term. It's, whether or not it's resistant because levodopa is not going to work because it's due to other non-dopaminergic pathways, or if it's related to poor absorption because of the GI metabolism. Those are completely different things. In those patients, for example, that do respond to levodopa, but they're only for a very short period of time, or they never can have that period of time where they're not eating protein because they're taking pills every 2 hours, so at all times there's protein in their stomach. It's at that time that we start to consider advanced therapies, for example, deep brain stimulation or duodopa, because they still have the capacity to respond to levodopa. We just have to think about an alternate way of treating them. For those people that have symptoms, despite the best effect of levodopa, we have to think about other strategies. So a lot of people come in having heard about involuntary movements, and they're terrified that if they take levodopa, that's what's going to happen to them. So the myth is that levodopa causes dyskinesia, these involuntary movements, in everyone that takes them. In fact, levodopa can cause dyskinesia, but not in everyone that takes levodopa. And we are always aware of this, and we always think about what the risks and benefits are. And indeed, keeping the medication at lower doses does reduce the risk of dyskinesia. But dyskinesia doesn't happen automatically. Dyskinesia happens at a certain point in Parkinson's that relates to how many of those dopamine-making cells are still in the brain. So, for example, if someone with very early Parkinson's comes in, has symptoms of Parkinson's, let's say with a resting tremor, and they don't take medication for a period of 5 years, they've been living with that resting tremor, and then at 5 years they start taking levodopa, it could be that at that period of time they'll take the levodopa and they'll get the dyskinesia right away. As opposed to had they taken it early on and they wouldn't have gotten dyskinesia at all. That is because the dyskinesia really has more to do with the state of your brain than it does to do with the medication. You won't get dyskinesia if you don't take levodopa, but the dyskinesia really relate to the stage of Parkinson's. Again, even if you do get dyskinesia, we have all kinds of different strategies to reduce them and manage them. And it in and of itself shouldn't be a reason to be afraid of levodopa. Dyskinesia can happen in different settings, and if in fact you do start to get involuntary movements, the doctor will need to know when in the course of your taking medications does involuntary movement happen. Does it happen as a peak dose effect, meaning you take your pill at 7 and it kicks in at 7:30, and then at 8 o'clock you start to get involuntary movements, or does it happen as a wearing off effect? For example, if you're due to take your next dose at 11, you start to note involuntary movement at 10:30. The doctor will change the medication schedule depending on where in the cycle the dyskinesia occur. And now people think of dyskinesia and they think of these flinging wild, crazy movements. That it doesn't happen that way. It happens with very subtle, slight changes. And if doctors are in tune and paying attention, they can make changes early enough without them becoming disabling. It's just over time at high doses, it may be that they can get more significant. So, as I said, dyskinesia can be managed by your doctor with appropriate medication adjustment. As I mentioned, there's a few websites here for you to look into. The top one, www.livewellwithparkinsons.com, is the website that I created. Keep in mind, I'm a doctor, not a web designer, so it is it has all the content, but it may not be a perfect website if I were to have been a web designer. And we're actually working on it to improve navigatability, but the content is all there, and hopefully you'll find it useful. Our clinic is www.assistivetechnologyclinic.ca, and if you go into the movement disorder section, you'll see the extent of the interdisciplinary team. I really feel strongly that an interdisciplinary team is important in managing symptoms of Parkinson's, because it affects so many different aspects of our life. And we have a dietitian, a pharmacist, a physical therapist, occupational therapist, speech therapist, and various other, we're actually a technology clinic, so various other different innovative approaches to managing issues associated with Parkinson's disease. And of course, the Parkinson's Society website that is hosting this webinar. So I just want to acknowledge our sponsors and to thank you for your attention today. And if anybody has questions, now would be the time to address them.
Wonderful. Thank you so much, Dr. Kleiner, for that informative webinar. I know medication usage in Parkinson's is always a popular subject because if you think about it, medications, there's always advancement in the field, and it is the closest thing we can that can help alleviate the symptoms, right? So we do have a couple questions. One is not really a question, it's more of a statement, but my husband has Parkinson's and he's on Cinemet 100/25, 2 tabs. It helps his stiffness, but it doesn't help in terms of movement and freezing of feet. Is there a reason for this?
Well, as hopefully you got the message from my presentation, there are a lot of different factors that I as a doctor would want to know before I said that the levodopa wasn't working. For example, I'd want to know what are the intervals of medications when he's taking two tablets, but when is it? Is it 2 tablets every 4 hours? Is it 2 tablets every 3 hours? Are the problems related to walking anytime, or are they at the time, or is there a wearing off effect of the medication such that he's walking okay for a period of 2 hours and then it declines, because that would be require an adjustment of the levodopa as to what I'd mentioned earlier, either a shorter interval, either a higher dose, either additional medications, or even at his best on, he doesn't have a good effect like freezing of gait. The first question I'd want to be sure of is, in fact, is this related? Is this idiopathic Parkinson's disease? Or is this some kind of a cousin to Parkinson's disease? In Parkinson's disease, medication usually works very well. Some cousins to Parkinson's disease may not have the same kind of benefit. So it's not possible for me to answer that question simply. It's something that a doctor would really need to do a full evaluation in order to be able to determine, has levodopa really been maximized, and or is there further modifications that could be made?
Wonderful. What do you think is the best exercise? My husband and I like to bike, but he has a lot of fatigue.
That's an excellent question. And there's, as I said, there's increasing evidence in Parkinson's that exercise is incredibly important as a neuroprotective agent, both in terms of mobility, in terms of thinking, and in terms of mood. So studies have been done looking at people that have and haven't had exercise, and they've, especially in Parkinson's, and they show substantial preservation of cognition, improvement in mood and depression, and sustained mobility in those that have exercised vigorously. Recently, there are, first of all exercise is excellent, and people should have a diverse exercise program, but I would strongly encourage people as much as possible to do high intensity exercise. So there was a study that showed that about 15 minutes a day of high intensity exercise 4 or 5 days a week, that means 85% of your heart rate max, it allows for that neuroprotective benefit. Now, sometimes people, you'd really want to work with a physical therapist to guide you as to how to do that in a safe way. Meaning, if you have balance issues, I don't know if riding a bike is safe. Although you could do it on a stationary bike, or you could do it swimming, or there's all kinds of different strategies, and you also take into account what people enjoy. A lot of people that come to our clinic have been going to it's boxing with Parkinson's disease. So it's called rock steady boxing, and that is a very good sort of whole body exercise and gets your heart rate up. It helps. They do all sorts of different exercises that people enjoy, and there's socialization and so forth. What's important is just really to get out there and do it, whatever it is, and do it every day. We encourage like cross-country pole walking, because sometimes people have a stooped posture, and by using the cross-country poles, it forces people to open up their shoulders and really increase their stride length, and you can certainly get your heart rate up doing that. There's lots to be said for strengthening exercises. I think as long as you exercise, it's good.
Thank you. So another question that we have is to clarify, if you eat a meal without protein, you can then take the medication shortly after eating, say within half hour?
Sure, except that people have no idea how protein is in so many different foods. So oftentimes, when even we spend a lot of time in an appointment talking about maintaining protein away from levodopa, and people come back and say, the pill's not working for me. I have no idea why. Um, and they say, no, I haven't been eating protein. I've only had peanuts, or I've only eaten oatmeal. And then I say, okay, cut out the peanuts with your levodopa, and all of a sudden they're walking again. So it's on my website, Live Well with Parkinson's. There is a tab for additional links, and one of them is a database of all the different foods that have protein in them, and it's important to review that to understand that even pasta, even bread has protein, milk has protein. So if you want to be sure you don't have protein, bananas, fruits, but most things do have protein. So it's best to just get into kind of routine of taking the pills and then eating half an hour later.
Awesome. So we do have an email question. It was suggested by my doctor to try, I don't know how to pronounce this word, so I'm so sorry,
Rasagiline. Okay, yeah, rasagiline.
Instead of selegiline,
Okay.
to improve efficiency of levodopa absorption. However, the difference in cost is very significant. Is it worth the increased cost? I do not have coverage for medication, therefore I have to pay for my own medication.
In all honesty, I do not believe it's worth the cost. Selegiline and rasagiline are cousins. They essentially, they're both MAOB inhibitors. The idea is that you try and block the metabolism of the levodopa so it doesn't degenerate quickly. It may give you an extra half an hour, but selegiline, if it's going to happen, selegiline will do it just like rasagiline. So the other names for rasagiline is Azilect, and selegiline is Deprenil. Deprenil is just an older drug, but they're essentially the same drug, and it's more kind of a marketing thing to say, well, this is a newer drug, therefore it must be better. It's not specifically better.
Okay. We kind of answered this, but maybe we can touch base more. Is there anything that could be taken to increase the dopamine naturally in the body besides Cinemet?
No, because people, it's pretty complex, the whole metabolism, and people go eating fava beans and various other different maybe homeopathic remedies. It actually potentially really makes it very difficult for a doctor to manage the medications, because you have no idea really what is going on, and if there are side effects related to involuntary movements. I would counsel people not to look for alternative sorts of sources of dopamine.
Okay. This is a statement, and I think he also was hoping to get more articles to understand the treatment better. But he says, as I understand things, Duodopa is a fairly new medication designed to help patients with advanced Parkinson's disease. If Duodopa is not already a topic of the presenters in their program, what can they tell us about Duodopa? I've been trying to learn more about it, but with not much success.
Okay, well, Duodopa is actually not a new drug. It's been in Europe for at least 20 years, very successfully. As I mentioned, it is for those people with advanced Parkinson's that still have response to levodopa, but may have a very narrow therapeutic window, may have involuntary movements that are difficult to control, because whatever you do, you increase the dose, you get more involuntary movements, you decrease the dose, you get more freezing, or there's an inconsistent response to the medication. This is usually all due to that GI metabolism, at which point by having a continuous infusion into the jejunum, into the small intestine, then you can bypass those fluctuations. And in fact, at our center, we are one of the centers that does perform Duodopa. It's an excellent treatment for the right candidate. And if your doctor feels that they've exhausted what they can do with levodopa or the other oral medications, they can certainly make a referral to us, and we'll do an expedited assessment to determine if you're a candidate, and then move it forward from there.
Wonderful. That is all the questions right now. Does anybody have further questions at this point in time? If not, and you need more time to think about it, you can email me. You can get that information on our website. A couple announcements though. Drooling and Parkinson's is our next webinar next month before the summer months. We do not have webinars during these summer months, which is July and August. So June 19th between 12 and 1 by Dr. Barbara Connolly. The registration link is below. We also will have a care partner workshop taking place in Chesley, Ontario on June 13th at Clagus Mill and Garden. This is strictly for care partners to anyone who is looking after their loved ones with any type of chronic illness or disease. So feel free to go to our website to register for that, because we do have the registration page open. And then lastly, we do have Walk It coming up in September. So look out for Walk It posters in your region. Walk It for Parkinson's takes place usually between the 9th and the 16th. And if you have any questions about that, we'd be happy to answer your questions through our phone line at 1-888-851-7376. Dr. Kleiner, thank you so much for being part of this webinar today. We really appreciate your words of wisdom, but also your knowledge, because you possess so much of it in this field, and it's always an honor to listen to you speak.
Thank you so much. It was a great opportunity for me. Thank you.
No problem. Thank you again, everybody, and hope to see you at our next webinar on June 19th. And if you have any questions for Dr. Kleiner, I can forward them to her if she has time to review them. I know she's a busy woman, so take care, and thank you again.